Welcome back to Boss Moves and Benefits. This is Ken Ball, president of CBC. On this episode, we've titled it Rx Disruptors. And we're going to be talking about pharmacy benefit management. Today with me is my co-host, Robin Ball, founder and CEO at Custom Benefit Consultants. And joining us are Jonathan Har-Even, vice president of sales at Navitus, as well as Kristin Hamilton, who's the managing vice president of key accounts. So before we dive in to pharmacy benefit management and PBM and value proposition of Navitus and some of the cool things that we're doing here at the CBC Health Insurance Marketplace for Costco members, thought we'd just talk a little bit about you guys. Jonathan, how did you get into the PBM space? Tell us a little bit about your background.
Oh, where to start? In high school debate, I actually debated the Hillary Clinton healthcare plan. So
that's interesting. That was kind of how I decided to major in healthcare administration.
Really? Oh yeah, and then I got my master's in healthcare administration.
You have to tell them what you did.
So there you go.
Why did that get you into?
Because I did billing in high school and college, and they were talking about implementing healthcare reform. I looked around my office and I thought, geez, if these are the people running healthcare, I'm going to dominate. Turns out there's a lot of smart people.
Right. Yeah. So then I got my master's in public administration, and I have since been sort of on every side of the table. So I've been on the vendor side, the HR side, multiple consulting sides, and also put together some healthcare coalitions and did some of that stuff too. So
nice. Word has it you're a DJ as well.
Oh yes,
that's his fun side.
Yeah, that's thank you for saying that, because there are a lot of ums and oohs. So I'm a DJ as well. My DJ name is Kosha, like kosher, Kosha Wax, which is I guess a little dated because that refers to vinyl.
Yeah.
But I started DJing right around the time I guess right after I started getting into healthcare. So those two things have been parallel tracks in my life. And I DJ mostly in New York City. I just did the Hotel Chelsea and a lounge in New York City as well. I just did a 50th surprise party and also a bat mitzvah. So I'm very, very versatile. Some would say cool, some would say not cool. So depends on the audience.
Awesome. How about you, Kristin? How'd you get into pharmacy benefit management?
Oh, gonna date myself here. I've been in healthcare 25, 30 years. Started out more on the administration side, so running an ophthalmology practice, business operations, and then moved more into the corporate contracting space in specialty. And so I've always been more in that business development, client-facing, contracting world, and then moved into consulting, which was focusing on pharmacy benefits. So worked for a very large national consultant and wanted to move into something more altruistic, making sure that I was really following my heart. And joining Navitus was just that, because of the organization and the culture, being able to be a businesswoman, but also do something that, feels good and brings value to the message. I can sell that. There's a lot of times where sales is all about the mighty dollar and driving your own revenue, which is great. And, we eat what we kill. But in the end of the day, I wanted to sell something that was of value and bringing healthcare to the people who need it. Got personal experience where pharmaceuticals is, horribly expensive in my family with, ill family members. And I just saw how that erodes, and having a good quality insurance company, we could afford it, but not everybody else can. And so having to deal with the office and people calling who couldn't afford their meds, that's heartbreaking.
Yeah. I had a similar situation actually with my daughter who had leukemia. And I went to the pharmacy and saw the price. And I was working for PwC at the time. So, it's not like I was under-resourced. And the pharmacist actually might have even violated a clause by pointing me to cheaper alternatives. Mm-hmm. And I just realized at that moment, I was at my lowest. It was the first prescription for a chemo that I was filling for my daughter. And then you get hit with the actual price, right. And you're like, are you kidding me? I mean, this is how I'm being treated in this moment, right?
Yeah.
So
that's wild. What a story.
It's critical. So,
and what's your fun side, Kristin?
I'm kind of an adventure geek. I like to hike and take on challenges. I put a big carrot out there every so often. My most recent one would be with my son climbing Mount Kilimanjaro 2 years ago.
Hey, we did that
So,
too. We did that for
yeah.
my 50th with the oldest and youngest. But yeah,
Yep.
quite an adventure, huh?
My son gets me into things. So he had me jumping out of a plane on his 18th birthday. And when he
That's
graduated from
fun.
college, we trained for 9 months and we
Awesome.
summited Mount Kilimanjaro.
Yay.
Yeah, we did that
Yeah.
as well. So just backing up a little bit, we live in a world of jargon and acronyms, right? And it's easy to throw around PBM, HMO, PPO, specialty drugs, and we can have a conversation and people might not even know what we're talking about. So in as simply as you can, how would you define pharmacy benefit manager and the role that it plays?
This is a good question. And when I first started at Navitus, I had some team members, they were doing a fun summer event and interviewing new staff. And so they had this little Q&A for their new boss. And they said, okay, you're getting into the elevator with your grandmother and your grandma's friend. How do you describe what you do? What a great question.
Yeah.
So
It's
I
all
proceeded to, I know people are like, okay. And so I proceeded to tell her, I'm like, okay, I can explain this. And so I proceeded to tell him, it's like, how when you go to the doctor and you take your medical card because that's going to pay for your office visit, it's going to pay for your x-ray. If you go to the hospital, well, when you go to the pharmacy to get your prescription for your antibiotic because you're sick, that's what we do. We administer the prescription so that gets filled and paid.
So that's a very simple way of describing it.
Yeah.
And for our audience, the pharmacy benefit management is for, those clients that want to be self-funded or are currently self-funded, right? And, that's like kind of the target market. So everybody has a pharmacy benefit manager, whether you're fully insured or self-funded. They just don't understand what that is.
Right.
And then there's just been a lot of hullabaloo lately of that they're evildoers, right? So, Jonathan, how would you approach that of what's going on in the market now?
Well, I would first say that we are not an evildoer. We're a good doer. So we're the opposite. Yeah, the bottom line is that, sort of to my point before about my own personal experience, a lot of pharmacy benefit managers, the large ones, I will not name names, but them, they dominate over 80% of the marketplace, if not more. They make money off of people taking drugs, using drugs. So the more units that they can push out, whether they're generic or specialty, the more revenue they make, right? So that's a traditional PBM, and that's why they get slapped with an evildoer label.
Mm-hmm.
Not to promote us, but just to give you the other side of that, a pass-through PBM like us, we do not mark up any drugs. We're actually incentivized to save money for our clients and plan members, not to make money off their backs by giving them brand drugs instead of generics, by giving them 90-day specialty fills instead of 30-day. We are managing it tightly, but without disruption to the member.
It's kind of referred to often as the transparent model, right? Where
Correct.
There's a margin that can be had relative to what's negotiated on the price of a drug on any given day. Like when I try to describe this to clients and prospects, I have this vision of my head of like an air traffic controller, like some person who's sitting in a room, like, bargaining and negotiating drug prices all day, and they're going to get as much as they can get, but that doesn't always inure to the benefit of the client, which is the purchaser, the self-funded benefit plan, and ultimately the member, right, who's going to fulfill those drugs. So, in that sense, the price that's negotiated on any given day on behalf of Navitus always flows through to the benefit of the plan.
Right. And that's what we're on the Hill in DC regularly talking about transparency, educating legislators on what's the difference of the different PBM models out there and why not every PBM out there is evil. We applaud the competition. We applaud other companies that are coming out and working in that same transparency vein. But something's got to change with the traditional model, because we've got to pull costs out of the system, not keep infusing more costs for patients.
Yeah, and I think talking traditional versus transparent. Traditional, basically, a PBM will come out and say, "I will save you X percent of the average wholesale price," right? Or we call it on our acronym AWP, right?
Mm-hmm.
And then that's what we're looking at. Okay, so is this PBM going to be higher or lower to guarantee that discount, right? The difference is that with traditional, that discount, they withhold that discount. But if they do better, which oftentimes they do, especially in this model, then they get the difference as opposed to the employer getting the difference, right? I think
Right.
that that's the big one. And the other is also rebates, passing the rebates 100% through instead of taking a portion of those rebates. And
Exactly.
I think that's where it
exactly
gets its evil name. And even in the broker market, there's a lot of hands, and dispensing fees and other
Yep.
fees. And
There's I over 3 dozen, maybe even over 50 ways that PBMs can make money, because those are how sort of we're rolling those terms up into rebates and
Sure.
dispensing fees and so on. But the PBMs, the traditional PBMs, a lot of them are 1 or 2 or 3 steps ahead.
Oh yeah.
So they can change terms, they can move plans, they can do all sorts of things in order to obscure the pricing and
So
continue to
To
collect.
that end, how does cost plus impact, the pricing model, and how does that kind of cascade down?
Funny you should ask. So, Lumicera, our specialty pharmacy, is the only cost plus specialty pharmacy that we're aware of. And it was started more than 10 years ago. Again, following the same mission as Navitus, being transparent and pass through. And so you can see the cost of the drug to the invoice level. We're not marking up on top of that, adding in a patient management fee based on the cost and handling and shipping. And that's it. Very transparent, very pass through. And the good news is we're also coordinating and working with Costco, our owner, our client, on a new product for cost plus in the traditional space as well, rolling out effective January 1st. So a little bit of
exciting.
yes, hot off the
Breaking
press.
news.
Breaking news. So cost plus, you're not adding margin,
Right.
and you're not playing with discounts on spreadsheets. It's based at the acquisition cost, marking up from there. So you look at the invoice and you can see exactly what it was, rather than what a pharmacy network rate agreement was.
So, I think to Jonathan's point, almost kind of chips away at that gray area where people are able to play and hide margin.
Exactly.
Right. The traditional, I like to say, is you're shooting a moving platform from a moving target, right? Or shooting a moving target from a moving platform. We'll edit that.
Ken calls it air traffic controller.
Yeah, right.
They have the secret sauce and they can move, on a dime whenever they want.
Yeah,
I think as a
exactly.
consultant, where we've really struggled spreadsheeting and trying to talk to a client about traditional versus transparent, it's very difficult because they can manipulate the formulary and say they're going to put these high cost drugs in. We call it like pay and chase. So the client will go ahead and pay that high cost drug, and then they're going to get this big rebate every quarter. And they're going to tell you that that rebate is going to outweigh the transparent model, right? When we're looking at most generic formulary, biosimilar first, we can talk about that in a few minutes. But in practice, and we've been doing self-funding for 27 years, and transparent model came, pretty much in the middle of that 27 years, right? But we have not seen it in practice work, meaning that the traditional could outperform, and the big three will say, yes, we have the discounts, we have the rebates, and it's going to do it on a spreadsheet, but we haven't seen it work in practice.
Exactly. They'll promise great savings. And so when a client moves, that first year, they may see a drop, but it's not sustainable.
Yeah.
And our specialty where we are it's about trend management, driving those costs down, but then keeping them down and not inflating with added margin or hidden costs along the way.
No, Kim will say we're batting 1,000, but I would say our transition to that, we're seeing like an 18 to 22% reduction, and that philosophical change, especially with Humira and Stelara. We can talk about biosimilars.
Well, I say we're batting 1,000 because whenever we've been given the opportunity to do the thorough analysis and then implement based upon the evaluation of that, it has always worked. It's always delivered, the savings, and usually more than we discovered as part of the pricing exercise. Robin brought up something though that I wanted to kind of stop and talk about for a second, just the notion of manufacturer rebates. So again, I think something that's kind of out there more so in the public conversation, relative to pharmacy benefit management, relative to potential legislation. And then likewise, when we talk about some of the larger PBMs out there, often touting just how much rebates we're going to get, right? And I think what we observe is sometimes people are too focused on that. And so I guess just from your perspective in the pharmacy benefit management seat, how do you guys view that? How do you position that? And how, from a purchasing standpoint, should people be thinking about it?
The bottom line to us is that you follow lowest net cost drug. So you ignore the rebate. Unfortunately, we do have to play in the rebate game in the sense that we need to put that on a spreadsheet that's really built on a traditional lens. And really, it's the lowest net cost game. And what you're going to see over time, particularly now with the advent of biosimilars, Humira and Stelara, is that the spreadsheet is going to become less and less applicable to what we're doing. So back to rebates, the bottom line is that you want to focus on the most efficacious drug at the lowest cost.
Nice word.
It's really simple. What I say when people ask me what I do, I'm not as eloquent as Kristin is. But I say, look, none of this is really that complicated at the end of the day if you're doing the right things. And that's what we do. And it's really focusing as best we can on lowest net cost.
And it's a continuous education process, depending on the broker, general brokers, pharmacy experts, and what's important to the client and the employers. Some have been fed that the discounts and rebates matter. And so we understand that is the way the industry is right now. We have robust rebate relationships and contracts, but we're not rebate chasers.
Right. It's a big difference.
There's a big difference. We're not focused on a high rebate formulary. We're focused on managing a tight formulary based on clinical efficacy and lowest net cost. And working in that vein so that at the end of the year, when they're looking at their dollars and cents, it's true numbers.
Right.
And another thing I want to bring up, which is sort of proof in the pudding here, is if you look at our prior authorization rates, right, the rates of drugs that we approve, they're much significantly lower than traditional PBMs. We're not getting complaints or less healthy outcomes because of that, right? So it just goes to show again that there's just too much waste and greed really going through the system.
I agree. So yes, we want to talk a little bit about the product that we have developed through Navitus for the CBC marketplace for Costco members. And what was your thought when we first approached you about building this product, Kristin?
I think my first thought was just excitement to partner with somebody who gets it, who really wants to bring value and collaborate. And that's what we're doing. We're coming up with innovative ideas and ways to meet the client's needs and demonstrate value.
Exactly. And we were so excited. And that's one of the things with this partnership. Like right away, we had the same vision of what we want to do. We want to have a transparent model. We want to create something special for Costco. CBC's supported the marketplace for 27 years. So super excited about having you guys on board. Do you want to talk a little bit, Jonathan, about what changes or what value that we're trying to drive through the Costco relationship?
Yeah, the way I look at it is if we're aligned to the employer and the employee, both the advisor, CBC, and the PBM, we could essentially use every lever at our disposal to manage costs and maintain or improve health, right? So we have high value cost containment, and that would be something around, let's say, a copay assistance program. So on specialty drugs, on traditional drugs, we can get manufacturer funding for those drugs. That's just one example of many. Then you look at clinical management. So there's prior authorization and making sure that the right drugs are getting through to the right patients. And utilization management, sort of similar vein. And then we have service excellence as well. So we have things like if you're thinking of coming over to the program, patient management transition is one of the highlights. So essentially what we'll do is we'll help members, and we just did this for a very large commercial brand insurance company. We will essentially hold a member's hand through the transition process. So I think of it as really using everything in our disposal to manage costs and improve health. And in addition, depending on the size of the client, we could also add certainty to, say, the CFO or the head of benefits with a per member per month guarantee. So we're ensuring that you're not going to go over a certain amount of costs.
Had a lot of success with that too.
Mhm.
I mean, CBC, we do put our fees at risk in those scenarios. That's why what we want to do is let people come to us and do the repricing, do the exercise. There's not any commitment at that point to just show us, so we could show you what we could save, right? And then on top of that, putting our fees at risk, for the representation that we gave the client, I think that's a pretty powerful outcome.
We know that there's much more of an awareness relative to pharmacy benefit management,
Yeah.
one. And secondly, the president has come out and stated his expectation relative to, if nothing else, favored nation pricing. How do you view
Yeah.
the impact
I mean,
of
it
that?
would be nice if, I don't know how realistic it is, but the hope and the goal is someday the rebates go away and the drugs are just priced as they should be. You know what I mean? We're not
Exactly,
playing
yeah.
these games, and the member and the employer, they get the value up front, which is part of what we do day in and day out, especially with the generics and leading with the biosimilars, where we're not chasing the rebate. They're getting the value right away. A $30,000 Stelara drug with a significant rebate, you're waiting 90 to 120 days post-quarter to get that. So employers, the plan sponsor's paying for that up front. That's money. That's time and value of money, where we have a preferred agreement with Teva now with the biosimilar with near 85% upfront savings. That's huge.
I mean, if they're paying for it up front, I mean, oftentimes what we see is, especially with some of the larger PBMs, where they're discounting their admin fee for third-party administration and other services in exchange for control of that formulary and in exchange for receiving those rebates. And I have to say, especially if we're engaging with someone new, in about 3 questions, I can tell whether or not there's a huge opportunity. If they tell me that they've given up control of their formulary and their rebates in exchange for that admin fee, I'm like, let me explain what we can do for you.
Right.
Exactly.
Right.
We know there's millions of dollars of savings.
Yeah, I
at
can
that
tell
point,
when we get feedback in our proposals. Oh, your admin fee is high. Well, who are you comparing us to?
Yeah.
The following traditional BBMs. Yeah.
Well, and to build on what you were saying as far as kind of what's on the horizon,
Sure.
what's coming down the pike, we're seeing a lot of state-initiated legislation. Now, that's impacting in the Medicaid space first. Medicare will follow. Commercial will follow along. So when you look at the long term of that, where states are coming in saying, we're demanding pass-through in a Medicaid service provider. Okay, well, that's starting. And then it starts to kind of eke into other areas, especially Medicare, government on that, what they're acquiring drugs, and the commercial employer space starting to see this. And it's like, wait a minute, why is there such a delta between what they're paying and what we're paying?
Yeah.
So we want to continue to reinforce that. And we're going to see that, I think, more on a state by state initially.
We have a small group that's actually a new client for us, and it's a new client for you guys with, I'm not going to say the name. I was going to, but they were a 1,200 person group, and we did the repricing. They had Humira last year on the formulary. Costco created a product called Costco Direct, where you could go around the PBM and allow the employee to get it for free at a much lower cost than the biosimilar, right? And so we were proposing that because they were in a contract with their PBM, and so that they could have the savings, while they're in their current contract, and they were going to move to the new contract that was transparent the next year. So their current PBM would not allow them to do that. We did the analysis. They were spending $400,000 more to have Humira on their formulary for last year.
Mhm.
Absolutely crazy. This is only 1,200 person group, but I don't mean to be disrespectful for a 1,200 person group, but it's considered small in the self-funding,
It is.
arrangement. Q1 $1 million savings.
Mhm.
So it's
Yeah.
going to be one of our next big case studies. I mean, it just seems like highway robbery. I mean,
Mhm.
they were stuck with these very expensive drugs.
It is.
Yeah, and the transition is not that hard, right?
Not
We
a
were
peep. Not a peep.
not a
like,
peep.
no,
We
not a peep.
transitioned, I think, over on the Navitus Key side, so 5,000 employers and below, or 5,000 employees and below. We transitioned essentially everyone within months, other than a handful, for some doctor exception reason, but not a peep.
99% conversion
Yeah.
on Humira.
Wild. Yeah, we
Yeah.
haven't. I mean, we've been doing this for a while, probably even a little bit more aggressive than Navitus. You guys are doing it now where it's biosimilar first, you know what I mean? And we have not had historically any issues, in terms of member disruption or member dissatisfaction, I should say, like not at all.
Well, and you talk about $400,000 savings, and for some that may seem like a rounding error for a very, very large employer, but when you're looking at self-funded small employer plans, 1 or 2 sick patients can derail their pharmacy budget for a year. And so we work closely with them to understand where we can pull levers to keep the costs contained, manage the formularies appropriately, use our services, whether it's a copay service with the manufacturer sponsored copay plan, whether it's specialty access and going into patient, financial needs, and leveraging all of those areas for these types of savings that are needed for these small employer groups.
That you mentioned cost containment. We're going to hit on one more subject and then we'll go speed round, I think, after that. But GLP-1s, this is like the big hot topic, right? Majority of our clients, we have it where it's only for type 2 diabetes. Certainly, that could be expanded for employers, and we're coming up with creative ways of making it more manageable, if it's going to be part of the formulary or a carve-out program. But do you want to talk about the rise of GLP-1s and what that's doing for cost nationally?
It's interesting. It's explosive. Everybody knows it. We actually measure our trend with and without GLP-1s because it's such a significant, pop on the spreadsheet that we need to pull that out so people can see the difference and understand the impact of just this one disease class, of drug. Like anything, it's explosive for now. More competition, going to mean that we can soften the cost. We have put in a diagnosis edit for coming up on, I think, almost 2 years now for that diabetes 2 diagnosis in order to weed out the waste and minimize, off-label usage for those employers who do not want to cover it in other areas. And then if they do want to cover it in weight loss or the cardiovascular, we work with them to cover that and maximize whatever manufacturer-assisted programs that may exist.
I think what you've helped us do, for CBC, like our clients are hyper vigilant of not wanting to get that those costs go up when they don't need to. So we've been looking at the data that you guys are giving us, looking at the TPA data to make sure there's a type 2 diagnosis and that they're actually on medications. Some of those are new hires, so it doesn't show up yet. And it's kind of a flip because doctors are trying to allow their patients to get these medications, even if they're not type 2. So we appreciate that collaboration. That's a new one. And I think it's kind of another great thing, for us to tout that we're going to do those audits every quarter and make sure that if that is your strategy for just type 2 diabetes, that we're not going awry.
Yeah, continuous monitoring. It is key.
Yeah.
Yeah, I had a CFO from an existing client call last week. I wouldn't say in a panic, but there was a heightened level of concern that someone had told him that 61% of his employees were on GLP-1. And so I pulled the reporting to understand what the utilization was through the health plan. And we had already audited this particular plan to understand that every single person had a diagnosis of type 2 diabetes. And so I was able to go back to him and say, well, 61% of your employees may very well be on GLP-1s, but the plan is not paying for it. Your plan has utilization down in the 2.5% range, which is close to what we're seeing as a benchmark.
Yep, we've been monitoring the benchmark as well. We get brokers calling up in that panic mode.
Yeah.
The U.S. population for type 2 diabetes, I think it's somewhere around 6%. So we can look at our trend across our book of business. We're running in the 3.5% to 4%. And so we know that, yes, there may be outlying abuse. There's always a little bit of a shift, but we've deployed programs to really monitor it as closely as possible and continue to reinforce that through back end audits.
The flip side of that, in fairness, and into the collective, point that I think has been made here several times is that we are working towards the best clinical efficacy, right? I talked about the jargon right at the top, and I think a lot of times geez, we go down the rabbit hole of all the levers that we have to pull and all the different things that we need to do to be able to effectively manage these plans. But the number one thing that we're trying to do is help people live healthy lives. And GLP-1s have been recommended by the American Diabetes Association as a primary means of helping people with type 2 diabetes, right? So by no means are we trying to mitigate people's access to the care that they need, but it's about doing this in the most effective way that we can collectively.
Exactly.
Agreed.
Got some speed round questions?
Yeah, go for it.
Jonathan, on your DJ, what is the favorite tune that you enjoy?
Oh, absolutely. Groove is in the Heart.
Groove is
That's
in
the
the
one. Yeah, by D-Light. That is the one that I'll play right after, if it's a sort of sit down dinner situation, post cocktail hour, when I need people to get on the dance floor.
That's it.
I throw that on, and then I play Electric Avenue by Eddie Grant. Right? Remember that one?
Nice.
And I'll throw in some Prince maybe.
That gets
and
them a
then
little
I'll
bit
just-
moving. Yeah.
And then you get the ladies on the floor.
Yeah.
The ladies bring the men, and sometimes you retain the men. It depends.
So sometimes
Yeah.
you might have to have multiple partners.
Sometimes they're a little sheepish.
Got a good speed question?
Sure. Favorite Costco product, Kristin?
Oh my gosh. Favorite Costco product? It's chocolate. It's the
Ooh.
they've got the big salted caramels.
Oh, that's a new one. We haven't had that one mentioned.
Mm.
Robin, how about yours?
Favorite product?
Yeah.
It's always the pate. Christmas pate. I love it. I can't wait. Every year I'm like, because Ken goes to Costco. He's like our Costco person, and I'm like, is a pate out? Is a pate out? So I absolutely love it. Jonathan, if you were to have like your dream Costco collaboration with Navitus, what would that look like?
I think it would be a collaboration where we can access all of the other Costco partners coming together and sort of create a community around doing what's right in PBM and for Costco members and all plan members and use that as sort of momentum. Almost, I guess I would say a Costco coalition, if you will.
Yeah.
I love that.
Yeah, we're working toward, for years, I used to say, I would get so frustrated in dealing with other PBMs, and I would say, this stuff's going to end up on 60 Minutes one day,
Right.
I mean, this is bad. People don't understand what's behind the curtain, and so just to tell you guys, it is absolutely refreshing to work with a company and with people that we can rely upon to not just be transparent but honest and keep us honest, and that we're all working towards the same collective goal. We really appreciate that. And we appreciate you guys joining us here on Boss Moves and Benefits to talk about Rx Disruptors.
Well, thank you for having
Thank you
us.
guys so
This
much.
has been
This is
welcome.
terrific
a lot of fun.
and very air conditioned.
Yeah. In Vegas. Thanks, guys.